15 to 20 years ago. And we used to give it IM as well as IV. And we were given Demerol and morphine kind of equal, one or the other. But now they're finding that Demerol is not as effective IM as they once thought it was. So they've kind of been pulling away from giving Demerol. I will say you do see Demerol still used for conscious sedation at Vidant and Greenville. There's some other possible potential choices, but you might see Demerol given as a conscious sedation method rather than just for pain management. Oxycodone is a semisynthetic derivative with the action similar to that of morphine as well. As potent as morphine, 10 to 12 times more potent than codeine. So oxycodone is very beneficial. It's used for moderate to severe pain, and it's most effective in the relief of acute versus chronic pain. So let's treat the here and now as opposed to the chronic. Side effects: euphoria, sedation, constipation. Hepatotoxicity, especially with acetaminophen dosages, because oxycodone can be mixed with acetaminophen. And if it is mixed with Tylenol, it is called Percocet. If it's mixed with aspirin, it's called Percodan. Percocet is the drug that a lot of drug seekers are selling on the streets. This is what people will go and complain of pain. They'll get drugs and then go sell them. And that's such a misfortune. That's overuse and overabuse of something that could be beneficial. Fentanyl is, and we've talked about fentanyl in the past, I do know of. It's IMPO. Can be given IV, especially for conscious sedation. I believe fentanyl is what I had for wisdom teeth to be cut out. Transdermal. And fentanyl we usually see in a transdermal aspect or a Duragesic patch, and that's probably the most familiar that you will see, other than the aspect of the IV if you work with sedation. So the action is synthetic, similar to morphine, but more potent. It's about 75 to 125 times more, with a quicker onset and shorter duration. So the transdermal is very beneficial because it'll actually leak medicine out at a certain rate every so often, just because it's in a patch form. It's used as an adjunct drug to general and regional anesthesia and for breakthrough pain, especially with our cancer patients. We actually prescribe the Duragesic patch to help them for that breakthrough pain, and then they might take something in conjunction with that. It might be sublingual morphine to help them with the pain as well. Side effects, pretty much the same. I'm really not going to go into that. All right, we also have methadone. Methadone is a very good drug. It is highly addictive, which cannot be good, but we have found something good for it. Okay, so methadone can be given PO, sub-Q, IV, or IM. It is a synthetic derivative similar to morphine, but with longer duration. It lasts longer. Okay, it's highly addictive and it lasts longer, but the withdrawal symptoms are less intense. So now we have found some good in this. The use of methadone is for severe pain and detoxification. So what we do is we send the patients to a detox center. While they're there, we are going to give them methadone, which makes it's highly addictive. So they're going to get addicted to the methadone to come off whatever their addiction is. When they come off their addiction, then we need to get them off the methadone because they have less withdrawal and it's less intense. So it's kind of, let's get them addicted to methadone to take them off the addiction of something else. And then once they are completely off the something else, then we'll take them off methadone. and their withdrawal symptoms will not be as intense. I will say, in my experience, the withdrawals from alcohol, the withdrawals from heroin that I have witnessed has been very tormentous to even take in. I often tell people that if we actually had video recording of the man that I recall that was withdrawn from heroin, I really believe that we'd have a better satisfaction of not trying those illegal drugs. It was just really, I could not even explain to you how bad it was to deal with that patient one-on-one all night. Through their withdrawals. So methadone is just a good way to help them detox so that they don't have those severe symptoms. And like I said, I think I've told y'all the story of the man with the heroin. He was so bad, I truly believe that we needed to intubate him. It had gotten that severe. And luckily we got enough medication in him that he finally started lulling down. But we used every bit of Ativan in house, and we were on a Valium drip there at the end. It was pretty intense. So with that being said, the biggest use for methadone is detox. All right, we're going to go into a patient-controlled analgesic, and I'm sure Miss House discussed with you PCA pumps when she talked about post-op management. PCA stands for patient-controlled analgesia. It's an opioid analgesic that's delivered intravenously through a special pump, and this special pump is a syringe pump, and it's a 50 milliliter syringe pump. It is more convenient for the nurse and it's more convenient for the client to use. It's an effective way to combat the problem of inadequate analgesia in the management of acute and chronic pain. The patient's in control. Okay, so we find that it empowers the patient, gives them greater control over the dosage of the opioid that they are to receive. They actually are more satisfied knowing that they can press a button and get their medication as opposed to hitting the call bell and waiting 10-15 minutes for the nurse to arrive with the medicine when the pain is already severe at that point. The pump, when you have a patient-controlled analgesia, the pump is actually programmed by two RNs for medication error prevention to deliver a certain amount of drug, which we call the demand dose, within a specific interval of time, which we call the lockout interval. And the doctor specifies the PCA demand dose and the lockout interval. So he's going to let us know what it is. Dosages typically are, so for example, morphine, we can give 1 to 2 milligrams, and that could be every 5 minutes to 15 minutes. Hydromorphone, 0.5 to 0.4 milligrams. Fentanyl, 12.5 to 25 mics. And the lockout interval, 5 to 15, anywhere in there. So the pump has a lockout on it, so no one can tamper with the settings or the medication. And the nurse must monitor the pump to make sure that it is operating correctly. And we need to monitor our patients. It's not just the equipment, it is our patients. Because if they're getting a narcotic through their IV, we need to make sure that we evaluate their respiratory rate, their sedation level, make sure that they're not getting too much. We need to assess their pain level, make sure that they're getting enough. So these are things that we need to evaluate. And we typically do that with a set of vital signs about every 4 hours. So let me just tell you a situation. I had a patient who was on a PCA pump. I had just gotten shift report and I hadn't really hit out to the floor. Once I got out to the floor, I went into my patient's room, and this was long before nurses checked PCAs. I went to my room and found my patient's respiratory rate was about 2 to 4. He was already paling up. So when I go in, I find him almost in a respiratory arrest situation. So what do you think I should do first? Let's talk about prioritization. What should I do first? Should I go get some Narcan, which is the antidote to reverse it? Should I go get an Ambu bag and start bagging him? Or should I call for help? What should I do first? Well, in the first aspect here, I'm going to call for help. Now, if you're at Vidant, ambu bags are usually on the back of the door, so you could be grabbing that while you're calling for help. But once you call for help, you need to get an ambu bag and start giving them rescue breaths while you call another nurse to get the Narcan. Okay, Narcan is the number one thing that we need to give them, but it's kind of a delegation of duties. Are you going to let the patient only breathe 2 to 4 and have an anoxic injury? Or are you going to breathe for them with oxygen flow and seek Narcan? Okay, so I'm walking into the room, identify my patient's not breathing, I'm going to call for help. And it's just your typical, Joe, are you okay? Joe's not okay. Go get me some help. So you seek help, get an ambu bag, give him rescue breaths, and have someone be pulling the Narcan to give that. Now, Narcan is the antidote. So as soon as we gave him the Narcan, it reversed the aspect of his respiratory rate of 2 to 4. He started breathing 8 to 10, and then it progressed to 12 once we gave him a second dose of Narcan. But if it reduced the effects of the respiratory depression, you must also understand that it also reduces the effect of the pain control. So at this point, he woke up in a lot of pain. But I'd rather him be in pain and breathing than the alternative. Transdermals, such as the Duragesic or fentanyl patch, just to reiterate, it provides a continuous pain control as it seeps out of the patch into the skin. It's used for chronic pain, mainly with our cancer patients. Patches come in various strengths and sizes, and it's very important that we follow the instructions regarding the removal and reapplication, as well as avoiding heat. If your patient becomes hot and feverish, that heat is going to make the medication absorb even quicker. So we need to be aware of that and check their sedation and respiratory levels. And then I have educated you well on do not cut a patch.